Here is a 70-year-old lady who presented with a phacolytic glaucoma a few days back, and these were her pressures at presentation, and she had a lot of inflammation. So patient was treated with steroids and anti-glaucoma medications to bring down the pressure, and even with all these medications, the pressure on the day of surgery was around 32, but with IV mannitol, it decreased to around 20 before the surgery, and she was taken to the OR. We can see that there is a calcification of the anticapsule and there is pseudoexfoliation as well. And there are a couple of issues which I need to be prepared for. Number one would be visibility will not be great because the milky fluid is going to escape out and cloud the visibility. Number two, because the presence of a long-standing cataract in an elderly patient along with pseudoexfoliation, I should be skeptical about the general health of the zonules. And third would be because there is a lack of epinuclear cushion in these patients, the risk of posterior capsule rupture in these hypermature cataracts during nucleus manipulation will be high. So I need to be mentally be prepared to anticipate and manage these issues. The eye is prepped and draped, and I'm planning to do the surgery under a posterior subtenance anesthesia. I'm giving 1.5 ml of lignocaine. The side put incisions are made, the capsule is stained, the IV is pressurized with OVD, and I'm making a conscious decision of creating a scleral incision here, not the limbal one. The idea is if in the event of an intraoperative complication and I would want to bail myself out, I would convert this incision to a sutureless sclerocorneal tunnel incision and then evacuate the nucleus manually. So that's the idea of creating this scleral incision. The anticapsule is punctured with the capsulorhexis forceps, and as expected, the milky cortical fluid escapes out. The flap is held with the forceps and the tearing is begun. The fluid cortex keeps on egressing out. The visibility is hampered, but nevertheless, I still have grip on the anticapsule. I'm aiming to create a rhexis of about 5 to 5.5 millimeter in size, and the rhexis is completed. I'm using HPMC to burp out all the liquid cortex, and this enhances the visibility. This time I realized that the rhexis is slightly smaller than what I would have liked. Using the micro scissors, I'm going to do tangential nick to the anticapsule through my left side port. The flap is then engaged with the micro forceps, and then the capsulorhexis is enlarged. I want to enlarge it from the other end as well. A similar snip is given onto the capsulotomy margin, and then using the rhexis forceps, I'm going to enlarge. So now we have a decent sized capsulorhexis, and managing the nucleus would be much more simpler with this side of a rhexis, because during lateral separation, the chances of exertion of stress on the rhexis margin and the capsular bag will be significantly reduced. So as I told in the introduction of this video, these are the cases where I would prefer to have the horizontal chop technique, although for most routine cases I always prefer to use the vertical chop technique. But these are the sort of cases which are best dealt with the horizontal chop technique. So let us go in very slow. The chamber is again filled with OVD, and to get a firmer grip into the core of the nucleus, I usually sculpt and create a small central trench so that I can bury and hold the nucleus in the central part. In these mobile nucleus, it's quite tricky to sculpt the nucleus because the nucleus will be moving around. So the trick here is to stabilize the nucleus with my second instrument as the trench is being done. I don't have to create a very deep trench. About 30 to 40% depth is good enough for me to go into the core of the nucleus, as this nucleus is not extremely hard. So now I'm switching my chopper to the long horizontal chopper. It's a modified Chang chopper. The phaco tip is buried into the substance of the nucleus using just the longitudinal energy in the burst mode. When the entire tip is buried, the nucleus is lifted up and slightly towards incision so that it's much more easier for the long chopper to go in and hook the equator of the nucleus, and then the chopper moves towards the direction of the phaco tip. This movement is very organic and looks very easy, and it's effortless to see how the nucleus cracks. But mind you, this crack is not going to go through and through. It will be half in length. And at this moment, I'm just not very keen to go ahead and separate the entire part because I want it to be least stressful to the zonules in the capsular bag. The nucleus is rotated. Time to do the next chop. Now have a look closely at the maneuvers. The first, the tip is buried into the substance of the nucleus. The nucleus is then pulled towards the incision and then at the same time lifted up a little bit. So the maneuvers are towards the incision and then a little bit up. And here the chopper goes in and hooks the equator of the nucleus and then moves towards the phacotip. Now this leads into the crack. In these denser nucleus, sometimes the posterior plate will be slightly tricky to separate. So I'm very conscious not to use excessive force during lateral separation. Whatever easily amenable to cracking, I'm cracking. Lest of all, I'm not pursuing it now. As I'm trying to do lateral separation, I lose the grip on the nucleus with the phacotip. So just leave it like that, rotate the nucleus, and again continue with my chopping maneuver. This time I'm consciously burying the phacotip into the slightly more deeper part of the nucleus. And then the same maneuver of pulling it towards the incision and slightly up and then hooking the equator of the nucleus with the chopper, and the chopper moves towards the phacotip. Here the full thickness crack is got and there's a small attachment in the posterior plate which is separated quite quickly with one maneuver. The next chop. As the lateral separation is being done here, I momentarily lose the grip on the nucleus piece which I'm holding with my phacotip. A short burst of phaco ensures that it goes in and holds the nucleus properly, and the lateral separation maneuvers ensures that the crack is now full thickness and the pieces are now free. The chopping process is continued, and this is the second heminucleus which is again chopped. And we can see that the posterior plate is still holding together. The fragments are lifted up. The chopper goes down and then cuts across these attachments between these two fragments of the posterior plate. So now most of the fragments are free and ready to be emulsified. So the emulsification has to be done in a very controlled manner. Using the right amount of parameters ensures that we don't have turbulence and we can minimize the trauma to the corneal endothelium. So as is my preferred technique, I always use my second instrument like the chopper in this case to guard or shepherd over the fragments which are being emulsified so that they don't jump around and hit the corneal endothelium. So time to replenish some OVD. Dispersive OVD goes in first, followed by HPMC. The remaining 3 fragments are then emulsified in the similar fashion. So once the nuclear fragments are emulsified, there's hardly any cortex to be aspirated. Time to put in the lens. The bag is inflated with OVD and the planned multi-piece hydrophobic lens is implanted into the capsular bag. OVD both in front and behind the lens is removed. The side ports incisions are hydrated. That's it, the case is done. These are the first day post-op pictures. The patient is quite happy with the visual outcome and the pressures are under control. She would be continued with anti-glaucoma medications for a couple of weeks and the pressures will always be monitored for the next couple of months. So in this case, we could see that performing the horizontal chop technique under direct visualization in this Morgagnian cataract was not so difficult. In fact, it is much more physiological. And I believe that in these Morgagnian cataract, it is probably the safest way to disassemble the nucleus. Thank you for watching and hope you found this helpful.